All right, thank you all so much for joining us today. As was mentioned, I'm Ann O'Day from the University of Kansas. I'm here stepping in for Dr. Jennifer Klemp, so I will do my best to fill in for her today. I would ask each of you to introduce yourselves and just share a little bit about your background before we jump in today.
Hello, I'm Arelis E Martir-Negron. I'm a medical geneticist with a background in internal medicine, and I work at the Miami Cancer Institute.
Good morning, everyone. I am Yara Feliciano, and I am an assistant professor at the University of Miami, the radiology department in the breast imaging section.
I'm Crain. I'm an advanced registered nurse practitioner, currently working at the University of Miami with the breast surgical oncology team.
Perfect. Thank you so much to each of you for joining us today. So today we're going to discuss some of the barriers to identification and genetic testing for our high-risk individuals. We're also going to work on describing some of the current standards for testing, some of the eligibility criteria. We're going to try to identify opportunities to incorporate shared decision-making into screening, management, and prevention strategies for our high-risk patients as well as our cancer survivors, and to demonstrate methods to improve clinic workflow, expand point-of-service identification, education, counseling and testing, and management of high-risk patients and our cancer survivors. All right, so we know that when we're approaching each of our patients in the clinic with a new diagnosis of breast cancer, we look at all of these comprehensive risk assessment, looking at everything from their hormonal history to their body mass index, their age, and certainly genetics is an important facet of that we're going to delve more into today. Risk stratification, of course, is key to effective screening and management. We know that the majority of breast cancers, of course, are going to be sporadic cancers. We're not able to identify a specific causality, but there is a large percentage of patients that have familial cancer. These are the patients that have perhaps a mother and a maternal aunt with breast cancer, but no identifiable genetic or hereditary mutation that we can identify. And then there's a small percentage, 5 to 10% of patients that have a truly hereditary cancer. And now I think we're going to ask Dr. Martir-Negron to kind of go through some of the semantics with us and definitions of germline and somatic mutations.
So germline mutations are changes that you were born with, and these are passed down. There are few genes like TP53 that you could be the first in the family to carry a mutation, so this is why even when we don't see anybody in the family, we will still recommend testing. And can you go? Okay. So a germline mutation is a mutation that you were born with, and this is when we send for hereditary panels. This is what we test for. A somatic mutation is a change that happened in one cell, and they continue growing and a tumor form. And this is when we do tumor testing, this is what we look at. So these are two different tests, and it's important to discuss this and tell the patient not all genetic testing are the same. And here we have, I mentioned a panel because now we are not testing only for BRCA1 and BRCA2 because we know that there are other genes associated with breast cancer. And I wanted to point out, you see the BRCA1 and BRCA2, these are the genes that has the highest risk of developing breast cancer. Close to that is PALB2, and there are genes that are moderately increased risk like BART1. Important also that and I want to make a big point, in the newer guidelines, they discuss what happens when you have two mutations in BRCA1, BRCA2, because it's important when we discuss if somebody carries a mutation and they're planning to have children, it's important to test the partner because there are conditions like Fanconi anemia, for ATM is ataxia telangiectasia that is important to discuss. So why we do cancer risk counseling and genetic testing? For surgical decision making, if somebody carries a mutation that increases the risk for a second breast cancer. When we talk about BRCA1 is 40% for a second breast cancer, 27% for a second breast cancer for BRCA2. Also, even though the mutation in guidelines doesn't say to discuss prophylactic mastectomy, when the patient learn what it means to going forward, then they in many cases they decide for radiation therapy. Well, if somebody carries a TP53, they need to know about the increased risk for other cancers. But obviously, if this is a safe, a life-saving decision, then we go ahead with radiation. The next. And this is also very important. When we talk about genetics, it's not about only the individual that we're talking about. We're talking about the family, the entire family. And this is something that is important, even though you see patients that have genetic testing in the past, maybe only for BRCA1 and BRCA2, they don't have disease now. You may say, well, maybe it's not important to test. Well, yes, because these are syndromes. It's not associated with only one cancer. And also this is an information that is very important for all family members and for treatment therapies that we have discussed during this meeting.
One of the questions that's come in virtually is if you might just comment about the genetic mutation ATM and the implications of radiation for those patients.
ATM, when there is one mutation, that is the one that we usually found, is in patients with breast cancer, increases the risk for breast cancer. Heterozygous, meaning somebody with one mutation, can have radiation. When we're talking about the one that we have to be careful with radiation is when there is two mutations, a biallelic mutation or a recessive, meaning that the two copies of the ATM is mutated. But again, this is, if it's a life-saving procedure, then we go ahead. Okay, this is something very important. Is the life of the patient that we're talking. If the patient has a lymph node that needs radiation, then we go ahead with radiation because it's a life-saving procedure. What I will not recommend is if somebody has two mutations and has cancer, I will say it's better to remove the other breast or the breast instead of having a lumpectomy because I don't want to have a radiation. But we're talking about nodal disease. I will say to go ahead, obviously with the discussion with the radiation oncologist, because this is a life-saving procedure.
Perfect, thank you so much. So we're going to talk about some of the methods to improve access to genetic testing. We know that it's a tremendous problem that testing rates remain very, very low. Some of the most recent literature suggests that about half of the patients in the breast cancer population that are eligible for testing are tested, so only about half of those patients. We know that this risk assessment is so critical because now it has significant implications for our treatment planning, not only for surgical management, but we know that we now have FDA-approved drugs, for example, PARP inhibitors, other treatments that are based on genetic or hereditary risk. It's also important so that we can design a plan of screening and risk-reducing recommendations. For example, does a patient want to take advantage of chemo prevention, and so on. That may depend or be influenced on that individual's degree of risk. We also want to think about cascade testing for family members so that when we get a positive test result, we can think about all the subsequent generations that can benefit from that. We also want to think about precision medicine and how this can improve outcomes and is also cost effective. We know that the barriers are persistent, and I might ask each of you if you just might share some of the barriers you encounter in your own practices, in your own systems that you've identified.
It's getting easier. It's getting better because the cost of genetic testing is way down. So we can do a panel for $250 that compared to two genes for $1,000 5 years ago is good. Also, the insurance are more open in covering testing. I think that you all remember the Angelina Jolie effect that helped to let the people know that the mutation can happen to everybody. But still there is a problem with genetic literacy in the medical field. When we go to med school, I took a class, like 5 months of genetics, and that's it. And you know maybe some syndromes, but you don't know enough to explain. So genetic literacy is important to feel comfortable talking about it. And we need more providers, genetic providers. That is also important. And to serve some areas And for that, I think that telemedicine has helped. Maybe if I can find a silver lining in the COVID situation is that for certain specialties like mine, telehealth have been very helpful. I have seen patients from Ocala, from Pensacola, from Jacksonville that I would have never been able to see, and I also have seen international patients.
In breast imaging, we don't necessarily do the genetic testing. We are in a big institution, so we refer those patients to the genetic services. I would say probably getting access to the geneticist, right? Many times you're overwhelmed, you have so many patients. So I would say that's one of the barriers, yeah.
I think in my practice, especially the location that we're at, is we have a lot of patients that either have come from other countries for care or their family members live in other countries. And one of the challenges that I see, especially with obtaining their family history, is many of them, the countries that they came from or received care in, they don't have genetic testing, or the medical records are not really readily available, or culturally they just don't share their medical conditions with other family members. So they know, grandma had a mastectomy, but we don't know why grandma had a mastectomy. So I think it definitely leaves a subset of a population that may potentially go unscreened and undetected.
Thank you. All right, so as I mentioned, if we look here at the top bar of, this is 2021 estimates based on annual incidence of hereditary cancer. Breast certainly is at the highest end here of annual incidence, over 284,000 cases, 44,000 deaths, and the percentage of hereditary cancer estimated to be between 12 and 14%. So that's just under 40,000 patients with hereditary cancer annually. So if we think about the fact that we're maybe only capturing about half of these people, and you imagine that continuing with an annual incidence, I know we like to use our institution the analogy of sort of a snowball rolling downhill, and we think about as that momentum gains and all the patients that we miss every year, when those patients potentially end up in their primary care doctors after they've finished their breast cancer treatment or in a survivorship program, you potentially can have hundreds or thousands of patients that you sort of have to go back and catch up and make sure it's tested. Certainly if you look at ovarian cancer here, about just under 25% of those patients considered to have hereditary cancer, and only about 5,000 of those are being tested every year. You can see there the numbers for uterine, colorectal, and prostate. So a tremendous opportunity for us to make improvements.
I want to make a point about that. You have seen 5, 10, 14. I want to tell you, I usually say 15. I cite 15 to my patients, and there is a fine line there that is that we're telling 14 because we're taking a consideration about the highest risk for ovarian cancer. So like a 15% is a number that I usually use. And for all these cases, we don't know where the location, and in big cities, you usually don't have that much problem, but there's small towns that could be a problem. When we talk about, it's very important as physicians to be able to say, I don't know, but I will refer. Because I have patients that come that said, I went to talk to my primary care physician, and he said, oh no, you don't need that. If there is a question, maybe the referring is a good idea, because that doesn't mean that person will be tested, but that person, we can identify who is the best person to test in the family, and we can tell you meet criteria, you don't, and we can give recommendations.
Yeah, and I'd like to add to that, especially from the nursing perspective, is utilizing the nursing discipline, because I feel like as providers, especially in oncology, we have a lot of time constraints, and a lot of these patients have very complex medical problems, not only their cancers. So I think utilizing, the nurses to help potentially screen those patients before they come in, help maybe obtain the genetic testing results, and bring it to the attention of the provider, because many times you guys have a lot to think about and to deal with that particular patient. So I think if we can bring that to your attention and just remind you, so it could be discussed at the visit, and even help with care coordination after that. And I think from an advanced practice role, utilizing billable providers like nurse practitioners or PAs to maybe help screen some of those patients. And if they don't meet criteria and they're not high risk, refer them back to their primary care doctor. And then the ones that we do identify that are high risk and maybe need some additional evaluation, then we could prioritize those and forward them on to their different specialties that they need to see.
Thank you so much for that. All right, so again, as I mentioned, there has been improvement in testing over time. If we look back to 2005, historically, only about 12% of eligible breast cancer patients were being tested. Now we're up to around 50%, but again, still a tremendous opportunity to intervene here for patients and subsequently their families. If we look at ovarian cancer, since 2008, all women with ovarian cancer qualify for testing. It's estimated that less than a third of the women with ovarian cancer are currently receiving testing. And of course, prostate is a bit of a moving target. The guidelines are still evolving, and so it's a little bit difficult to capture the data about how well we're doing with that, but I know that's something we're working to capture in our high-risk prostate clinic at our institution. As far as barriers to testing, you all have highlighted some of these. Historically, it's been available time, availability of the workforce, genetic counselors, and genetic experts, the cost, which is definitely improving, lack of organizational pathways. At some institutions, it's not knowing where to send the patient or how to get that patient an expedited referral. For example, if that patient needs testing, that's going to have implications for their surgical management. Provider comfort and knowledge. I know we have specific rotations for our medical oncology fellows, our breast surgery fellows, our breast imaging fellows through our genetics clinics, but many institutions don't have that, and so we need to make sure that for our trainees, that's something that we continue to educate our future providers. And then as far as health equity, we can look at things like insurance status, which sometimes might be perceived status or coverage of the test, and rural versus urban. I can tell you, practicing in a state where I have patients that often drive 6 hours to see me, we are very grateful for the use of telemedicine. It works ideally for genetic testing. And if you all want to make any other comments about any barriers or any strategies that you've utilized to overcome some of these.
There is still the idea that genetic testing is very expensive, and that is something that had remained in the mind of the patient, and that is not the case anymore, and is covered by the majority of the insurance. The telehealth is definitely, we have been using in general genetics telehealth, and we have been successful. The issue is the payer. There are ways that the genetic literacy can improve. For example, there are high intensive courses, courses in genetics that can be very helpful. But it's very important, and I'm sorry,
Ashley Crain.
Okay. She said it's important to utilize all your resources, and it's important because the time is definitely a constraint. It takes a lot of time to gather a good family history, and it takes a lot of time to explain something that is very foreign to some people that are in the field. Just imagine the patient, and it required the help of being able to explain in an easy way to understand. And as you can get help from your group, or try to find how you can get these courses and be better at explaining this. In terms of race, let me tell, and we'll discuss that in a moment, the data, we need diversity in the data, but I'm gonna discuss that in a moment.
Perfect. Okay, Dr. Martir-Negron, do you want to walk us through some of the types of mutations and classification, with particular attention to the updated 2022 NCCN guidelines? There are definitely some practice-changing implications for genetic testing.
When what you're seeing is when you see pathogenic, like the pathogenic variant of uncertain significance, so many different terms, that is more for molecular geneticists, okay? Because this is following the American College of Medical Genetics recommendation for variant reclassification, and maybe they need another paper to move it from likely pathogenic to pathogenic. Maybe they need more people or studies. But from the clinician standpoint, is a pathogenic and likely pathogenic is considered pathogenic. A variant of uncertain significance, I call it negative until proven otherwise, because a variant of uncertain significance is a change that we don't know, and we need more data to accumulate. And in many cases, the main problem that we have is that there is no variability in the data. Maybe that variant of uncertain significance in somebody from Hispanic background is very common in the country they came from, but in Latin America, we are not doing enough genetic testing. So then maybe that's a change that is very common in the population. The likely benign and benign from the genetic standpoint, from the clinician standpoint, is negative. And in the guidelines is explained this is for likely pathogenic, and pathogenic is sometimes difficult for the patient to understand. Likely, that means that it's not pathogenic, means that it may change, is unlikely to change. If you have asked me this 2 years ago, I would say, no, that will never change. But we added to the DNA, we do RNA now, and I had two patients that are the same mutation, their family, that it was reclassified from nothing. It was a benign change, and benign change are not reported to pathogenic, but that is very rare to happen. Okay, so usually the likely pathogenic will not go to be benign. It may be classified back to variant of uncertain significance, but it's very unlikely. Okay, we're getting better. So when you see a likely pathogenic, that is a positive result. Benign, unlikely benign, just so you know, that is not reported unless it was a variant of uncertain significance that has been downgraded. Okay? So when we talk to the patient and say, well, you have a variant of uncertain significance, but maybe you have many benign changes, but we don't report. We only report what we don't know for sure, and more data is going to accumulate, and when we have more data, we reach out to you, but you don't have to be worried. I always say there are many things in life to be worried about. A variant of uncertain significance is not. But no, whoever ordered the test will receive an amended report from the lab, and it's your responsibility to call the patient and say, there is a reclassification. Again, 90% of the cases, nothing. 10% of the cases is reclassified as to be pathogenic.
Do you want to cover some of the NCCN germline testing criteria that updated from 2022?
There are some that have been in the book for some time. The big one that from this year is that everybody with a triple negative should be tested. In the past was 60 years or younger, but now everybody who had a triple negative disease should consider genetic testing again, even if it was years ago. Why? Because these are syndromes associated with more than cancer, and you have family members. Individuals who are younger than 45, we recommend testing for ovarian, male breast cancer, and pancreatic cancer. We hear a lot about ovarian and pancreatic cancer, but really the risk of ovarian cancer is 1.3%, pancreatic is 1.7%. It's just the way that it presents that this is why we know a lot about them, but it's uncommon. And for male breast cancer, if the man doesn't carry a mutation, the risk is less than 1%. Metastatic breast cancer now, regardless the age, is important to test because of for treatment decision making for PARP inhibitors. If somebody has multiple cancer, why? Because when somebody carries a mutation, the risk for a second breast cancer is increased. We know for BRCA1 and BRCA2. We don't know for the other genes, and we explain that. We don't know what is the risk for a second breast cancer, but it's definitely increased. It takes time to get all this data. It took 20 years for the BRCA1 and BRCA2 data to come back with good numbers. We were saying 50% for everybody risk for a second breast cancer. We then learned that for the BRCA2, the risk is not 50, it's 27. It's still increased, and it still has to be discussed, but it's lower. And for family history, somebody's of Ashkenazi Jewish descent is not there, but very important in where we are. Bahamian population, there are founder mutations. So somebody's from the Bahamas is something that to take into consideration. And combination of different, because like I mentioned, these are syndromes. So it's associated with more than one cancer. And this is why a good family history is important. And this is an easy way to understand if you have 3 family members with breast and prostate cancer or any of the cancers associated with BRCA1 and BRCA2, even though we don't test for those only. It is recommended to be tested. If there is 2 cancer, one younger than 50, important. It could be in the same individual. It could be in a family member, first, second degree. We can use the 3rd degree if the individual is affected. First, only one if there is ovarian, if there is pancreatic cancer, metastatic prostate cancer, or Gleason score of 5, or if somebody died of prostate cancer. If somebody died of prostate cancer, you know the Gleason score was more than 7 because people doesn't walk around knowing the Gleason score of family members' prostate cancer. If there is limited information, if there is not enough females in the side of the family that could have developed, or if they died young, Ashkenazi Jewish descent, 1 in 40 versus 1 in 400 will carry a mutation in BRCA, 1 or 2. And a positive tumor somatic testing. This is very important. It's not every positive tumor because all the tumors will have tons of mutations. We're talking about high allele frequency. And what is considered high allele is 20%. But again, if you see a patient with a TP53 somatic mutation of 40%, you still send for testing. That doesn't mean that this individual lived from ini, because you can find TP53 in every tumor. Okay, that this is important to do the testing. It's important, but it's not for all the genes that you find in the somatic, because we don't test for all the genes in the germline world. We don't test for all the mutations that we see in the tumor.
And Dr. Martir-Negron, a question has come in asking, in your experience, how commonly do you see Li-Fraumeni syndrome?
Well, the situation is I see the uncommon. This is so I have seen many, but that is not common. It's just because this is the patients that I see. Usually, when you think about Li-Fraumeni, you think about a triple positive. Yesterday there was a case about triple positive. Not all the triple positive, but a triple positive. And also, if somebody's younger than 30, if you see osteosarcoma in the family, if you see rare tumors, leukemias, adrenocortical carcinoma. But this is why we do a panel, because we test always for Li-Fraumeni, even though it's not as common. There are found mutations in the Brazilian population, though, and we have Brazilian individuals in South Florida when I practice.
The other question that's come in about TP53 is any adverse impact of radiation?
Yes, there is an increased risk for other cancers, but again, if your life depends on doing the treatment, you do the treatment. Again, if somebody has DCIS, ductal carcinoma in situ, and I will say it's better to remove the breast and not do the lumpectomy, because you will need radiation, and it's not recommended. But if there is nodal disease, I will definitely recommend the radiation. Obviously, again, I'm not the radiation oncologist. This is run by them, but if it's a life-saving procedure, yes.
Perfect. All right. So putting the patient's risk into perspective, in practice, we all see those, majority of the patients we'll see in our clinics will have sort of average risk. Many of them will have, at least half of them will have some family history of breast cancer, and then the genetic risk. So how do you all in each of your practices collect that data from a system perspective in your electronic medical record? How do you update family histories and make sure that you're accurately collecting this information?
So at least in my practice, when patients come to have the screening mammogram, we always collect a family history, personal history of breast cancer. We do it electronically. When the patient comes to the clinic, they need to fill out a form, and then that form goes into the system. So we always take into consideration that information for screening.
Perfect. Ashley, how about you?
From our perspective, so I actually have my own clinic, so when I see those patients, a lot of times I'm obtaining that information myself. And I try to update that when the patients come back, because I have had some patients where, they've recently had a new family member diagnosed, which now makes them, a candidate to be evaluated further. As far as our breast cancer patients that are actively being seen or coming in for new patient visits, that's usually obtained by our nurse navigators. They try to obtain a pretty detailed history on the patient, ask them if they've had genetic testing. If they have, try to obtain those records for the oncologist that they're going to be seeing, and those are typically updated every visit. They should be updated by the nursing staff when the patient's getting their intake done, and then also by our team when we see them for their office visit as well.
Perfect.
Actually make a great point, and is to collect the test results, because you may have had genetic testing in the past, but it was not enough. Like before 2009, we were doing only part of BRCA1 and BRCA2. The other part, so is every genetic testing have two components, sequencing and deletion and duplication analysis. Only at that time they were doing sequencing, and 10% of the mutations are in the part that wasn't tested. And for some population, we said 10% of deletion and duplication, but let's say for the Mexican population, the most common mutation is in that 10% that wasn't tested. So this is very important to get the record, because maybe what it was done at that time was not enough.
Perfect. Thank you so much. Dr. Feliciano, do you want to walk us through some of the first case here?
Of course. So this is the first case. This is a 68-year-old female that she has a known CHEK2 gene mutation. She has past medical history of bilateral breast cancer. Initially, she was diagnosed at the age of 46 and was treated with lumpectomy and the standard of care for treatment. Her family history is significant for father with colon cancer and paternal grandmother with thyroid cancer. It is important to note that her screening mammogram 6 months ago was completely negative, no suspicious findings. However, now the recent MRI is a little bit different. CHEK2 mutation increases the risk of getting breast cancer by 15 to 40%. We usually recommend screening mammogram in this patient starting at the age of 40 or 5 to 10 years prior to the diagnosis in the first degree family member. The screening that we recommend is to get annual mammogram and then stagger that mammogram with supplemental screening contrast-enhanced breast MRI every 6 months. There's insufficient evidence to recommend for risk reduction strategies such as mastectomy, and this is managed based on family history. This was the mammogram for this patient. This is the MLO projection. We can see that the patient has some surgical changes related to the lumpectomies that she had at the age of 46. But the mammogram otherwise was completely negative. No suspicious masses, no calcifications. And that was the way the mammogram was reported. It was a BIRAS-2. However, we were doing intensive screening for this particular patient because she had personal history of breast cancer, the CHEK2 mutation. Another important finding to note in this mammogram is that she has very dense breast. And we know that by having dense breast, the sensitivity for the detection of breast cancer is going to be much lower. This was 6 months prior to presenting for this contrast-enhanced breast MRI. In the contrast-enhanced breast MRI, we can see that enhancing mass in the upper outer quadrant. By looking in retrospective to the mammogram, there was no way that we could see that. Maybe because she was very dense, or maybe because she just developed that mass 6 months after having the mammogram. At this point, we recommended to get a second look ultrasound. If we are able to find that mass with ultrasound, we prefer to biopsy under ultrasound guidance because it's going to be more comfortable for the patient, and the biopsy itself it's easier. We were very successful in finding that small mass in the right breast 11 o'clock axis, 7 centimeters from the nipple. The mass correlates perfectly to the finding on the MRI, so we proceeded with the ultrasound-guided core biopsy. And this, in fact, came invasive ductal carcinoma. So that was another cancer for this patient with CHEK2 mutation. When we have patients that come to our clinic for screening, and in every breast imaging center, it is important to stratify those patients depending on the risk factors for getting breast cancer. There are 3 categories. The first one is average risk. These are women that have less than 15% lifetime risk of getting breast cancer. And this is once we calculate the risk with one of the risk assessment model. For example, one of the most comprehensive one is the Titer-Cuzick, but that's going to depend if the patient, for example, has family history of breast cancer and other factors. For average risk women, we recommend mammogram. And we try to recommend that mammogram with tomosynthesis. Some patients may benefit from ultrasound, especially those patients with dense breasts, and this is something that we're going to discuss a little later. The second variant is patients who are intermediate risk, and that includes patients with personal history of breast cancer, lobular neoplasia, and atypical ductal hyperplasia, or with 15 to 20% lifetime risk of getting breast cancer. Again, we have to recommend that mammogram with tomosynthesis, And MRI or ultrasound may be appropriate in some patients depending on the additional risk factors. And the third category, the one that we're discussing today, is for patients with high risk. Those include, for example, women with BRCA mutation or their untested first-degree relatives, women with a history of chest irradiation between the ages of 10 to 30, and women with 20% or greater lifetime risk for breast cancer. For those women, we have to recommend mammogram with tomosynthesis and staggered that mammogram every 6 months with a supplemental screening breast ultrasound. Some patients may benefit from ultrasound, and those are patients who have some contraindication for getting the breast MRI. One important subgroup that we always have to discuss as part of the high-risk population is the patients who have received a mantle radiation as children or adolescents. Those patients, we know that they have 30 to 20% will develop breast cancer by the age of 40 to 45. And for that reason, we have to recommend screening mammogram and MRI every year, starting at the age of 25 or 8 years after the completion of the therapy, whichever is later. So this is something very important to keep in mind.
I want to say something.
Yeah.
If you have somebody who had with this history receiving mantle radiation, you still will recommend genetic testing given the age of the diagnosis. Also, that will take into consideration why the person had, if there is any cancers, and we look at the family history. But you should not assume that that is the only reason why the patient had the cancer. Then when the results come back, if they're negative, we say this is likely the cause that you received mantle radiation. But it's important just not say, oh, I'm going to do testing because I know the reason. No, we do genetic testing because of the age of diagnosis.
That's important. Very good. Like you said, like I mentioned before, we try to recommend the diagnostic mammogram with tomosynthesis. And I think most of the places who do, that do screening mammogram, they have that capability of doing with tomosynthesis. Tomosynthesis, it's a very well-known imaging modality that we know that increases the detection for breast cancer and decreases the false positive recalls. One of the things that we always, a lot of people don't like about mammogram is that many patients, once they have the screening mammogram, we have to call them back to do additional views or to do ultrasounds. And that increases the anxiety of the patient and also the cost of having that screening breast imaging. However, by doing the tomosynthesis, we're gonna decrease those recall rates. And we're also increasing the cancer detection. And this is especially important in patients who are high risk, that we know that we have to start screening at a very early age, and most of them are gonna have dense breast, and we know that tomosynthesis is especially important in patients who are dense breast because it increases the detection of the breast cancer. This is just an example of how tomosynthesis helps in the detection of breast cancer. To the left side, we have a picture for 2D mammogram. The 2D mammogram, the problem is that many times we have overlapping breast tissue that may obscure that tumor, the spiculated mass. But when we do tomosynthesis, since we're getting multiple pictures throughout the breast that we have to evaluate in one of the workstations, we can definitely see that spiculated mass that is completely distinct from the overlapping breast tissue. And these are just two images. The left side is the tomosynthesis. We can see the spiculated, ugly-looking mass that was biopsy-proven cancer. But then the same patient, we did a 2D mammogram, and the finding almost looks like overlapping breast tissue, like superimposed breast tissue. So that's one of the importance of doing tomosynthesis. The other advantage of doing tomosynthesis is that sometimes in the 2D mammogram, we can see a spiculated mass that in reality is just normal breast tissue that looks like something suspicious, right? But when we evaluate those lyses in tomosynthesis, we know that it's superimposed breast tissue, it's not something concerning, and we don't necessarily have to call that patient back for additional screening. So those are two of the advantages of tomosynthesis. Sometimes we recommend ultrasound, especially in patients who are high risk, that we anyways have to recommend supplemental screening MRI, but that for some reason they can't go for the MRI, right? Some of them are very claustrophobic, some of them have pacemakers, devices that are not compatible with the MRI, or some of them have metallic devices, right, that we cannot get that MRI. Ultrasound is a modality that we can offer to those patients. Another group that we also offered ultrasound is patients who have very dense breasts, right? And this is something that I think it's very important to have that conversation with the patient and discuss the benefits and the risk of getting that additional modality for the detection of breast cancer. This is just a diagram of the different breast densities that we have. The first thing that you're gonna notice in the mammography report is the density of the breast, right? And that tells you how sensitive is that mammogram for the detection of breast cancer. So you can imagine that for the first two, the fatty and the scattered, those are considered non-dense patients. For me, it's gonna be easier to detect breast cancer in those two patients. So we don't necessarily recommend supplemental screening ultrasound. However, for the other two, the heterogeneously dense breast and the extremely dense breast, many times the cancer can obscure in that fibroglandular breast tissue, and it's gonna be difficult to distinguish that breast cancer. So for the last two, we tend to recommend supplemental screening ultrasound. It is important to know that the majority of the states, they currently have legislation that all screened women should be notified about the density of the breast. And then it's important to know that the patient and the referring physician, they need to have a conversation of doing supplemental screening, right? Once they discuss the benefits and the risks of that supplemental screening. And Florida is one of those states. One of the advantages of having ultrasound is that it's widely available. I think almost every institution has access to ultrasound. It's an inexpensive tool compared to, for example, MRI or other breast imaging modalities. It's very well tolerated by patients, and it allows for immediate intervention. If we see a mass, we can definitely do the ultrasound biopsy the same day. However, some of the disadvantages of ultrasound that we need to discuss is that it's skilled operator, right? Not all the ultrasound techs have the same capability to find tumors. May lead to interventions. We do a lot of biopsies that are gonna be completely benign, but by looking at the finding, we don't know if it's something benign or malignant, so that's the reason we have to proceed with the biopsy. That decreases the positive predictive value of ultrasound. And it also increases follow-up exams, right? Once the patient has that ultrasound, many times we're gonna see findings that we have to recommend follow-up in 6 months. That's the category 3, right? And that increases a lot of anxiety for those patients. One important study to discuss in the setting of high-risk patients is the EVA trial. This trial included high-risk patients that were screened with different imaging modalities, either alone or in combination. From this diagram, we see that the combination of mammogram and MRI detected the highest number of breast cancer. But by adding that ultrasound, we don't necessarily increase the cancer detection rate. On the other hand, what we did is that we did more unnecessary biopsies for benign findings and more follow-ups. So that's the reason that for high-risk patients, the recommendation is to do mammogram and then ideally staggered that mammogram with supplemental MRI every 6 months. The American Cancer Society recommends annual screening MRI for patients with BRCA mutation, first-degree relative of BRCA carrier but untested, women with more than 20 to 20% lifetime risk with BRCA Pro or other model, depending on the family history, the genetic syndromes that we discussed before, and like we said before, radiation to the chest wall between the ages of 10 to 30 years.
Dr. Feliciano, I might just stop you for 1 second. We're getting lots of questions coming in about the impact of gadolinium over time with annual MRI, specifically questions about gadolinium uptake in the brain.
Yeah.
With annual screening, I know I have many young BRCA patients in my practice that are 27, 28, and they're starting to get annual MRIs at a very young age.
Yeah.
And that's something that's on their minds.
So we're going to discuss that now, how we recommend the screening. For gadolinium, we know that the gadolinium deposits in the brain, right? But we still don't know the effects in a long term. That's something that maybe many years from now we're going to know what exactly it's happening, right? However, the benefits of having the MRI, it's more than the risk, at least right now, like we saw in this patient, right? The only way that we were able to detect that tumor was with the MRI. And we try to get that tumor as small as possible so that we can offer better treatment for this patient. But definitely, that's something that we still are studying, right? These are the different genetic mutations, and this is the most recent recommendations from the NCCN 2022. For patients with TP53, the recommendation is to start MRI from 20 to 29, and then after 30 to 75, we recommend staggered mammogram with MRI. After 75, it's going to be case by case, especially taking into consideration the health of that patient, right? Then we have BRCA 1 and 2. For those patients, we recommend MRI starting at the age of 25 to 29, and then after 30, mammogram with MRI. For patients with STK11, the recommendation is mammogram and MRI from 35 to 75. Patients with POP2 and P10, the recommendation is mammogram and MRI starting at the age of 30. Patients with CVH1, the recommendation is to start mammogram at 30 and then consider MRI. And then we have the 3 additional genetic mutations, CHEK2, BARD1, and ATM. Like our patient, the recommendation is to start mammogram at the age of 40 and consider that MRI. These are the most current guidelines.
And again, taking into consideration the ages of diagnosis in the family, especially if we know where the mutation comes from. So if it's earlier, we will start earlier the screening.
And then this is another modality that I want to discuss with you. Some practices, they also offer contrast-enhanced mammogram. If for some reason the patient cannot undergo contrast-enhanced breast MRI, supplemental MRI, I prefer to offer contrast mammogram than ultrasound. Many studies have proven that contrast mammography has similar sensitivity for the detection of breast cancer as MRI, and the specificity may be even higher, right? One of the disadvantages of MRI is that if we see something that is enhancing and we don't know that it's benign in a high-risk patient, many times we have to recommend biopsy, right? And that decreases the positive predictive value for that exam. However, we're noticing that with contrast mammography, that specificity increases, right? So this is another modality that we offer to our patients. This is a patient, in this case, we didn't do it because she was higher risk. We did it because she had a lot of post-surgical changes. This is a patient that had implants. She had a silicone extravasation in the breast. So the mammogram, like you can see, the 2D mammogram was very difficult to read. And the sensitivity for the detection of breast cancer was very low. So we decided to proceed with that contrast-enhanced mammogram. With this modality, we have to inject contrast. It's going to be iodinated contrast, so that can be a little bit of a disadvantage, especially in patients who have some type of allergy to iodinated contrast. But for patients who don't have any type of allergy and the renal function is good, we proceed with this exam, right? And many times it's very well tolerated by patients. They even prefer doing contrast-enhanced mammogram than MRI, especially, for example, in patients that are claustrophobic. If you have a patient that says, no, I really don't want to get that MRI because I'm claustrophobic, I hate it, I don't like it, this is something to consider, okay? It's easy. It can take maybe like an hour between the time of getting the access line to reading the study. And what we do is that we obtain 2 images. One, low energy, like the 2D mammogram that we have to read to find calcifications or any other findings, and then a high energy. Once we obtain those 2 images, we subtract the images, and what we get is the second image where we see the enhancement, right? If we see an enhancing lesion, that person can go directly to the ultrasound, and we're trying to find those findings for biopsy. This particular patient, if you see the 2D mammogram, there's no way that we can see that enhancing lesion in the 2D mammogram. In the contrast-enhanced mammogram, we were able to identify that enhancing mass. This patient, she had the ultrasound just after the mammogram, and then the biopsy, and this was a cancer that was obscured by the remaining fibroglandular breast tissue. So this is another modality that we can offer to the high-risk patients. Just in summary, patients with 20% or greater lifetime risk of getting breast cancer, the American Cancer Society and the NCCN guidelines recommend annual mammogram staggered every 6 months with the MRI, and the reason for that is that we're going to detect the interval cancers. Those are cancers that develop within the year of screening. And ultrasound doesn't add anything to that combination of mammogram for MRI, like we discussed with the EVA trial. And again, the best thing to do, if the patient is able to do it, is to stagger that mammogram with the MRI every 6 months.
Ashley, we'll ask you to take us through the first question here.
Sure. So we just have a couple questions to round out our panel. So a 26-year-old female comes to your clinic with a pathogenic CDH1 mutation. You know to educate them on the following. So their lifetime risk of breast cancer is between 41 to 60%. They have an increased risk of gastric cancer. They should undergo annual screening breast ultrasound starting now, with mammography starting at age 30. They should undergo annual screening mammography and breast MRI at age 30. Dr. Feliciano, do you mind pushing that?
Oh, sorry.
It's okay, thank you. Oh,
No.
we lost it. Okay. So the answers would be that their lifetime risk is between, that should be 41 to 60%. They have an increased risk of gastric cancer, and they should actually start their annual screening mammogram and breast MRI at age 30. I do see a lot of times in the community when I have patients come in that primary care doctors have ordered a lot of, and maybe Dr. Feliciano could speak to this, but because they're 20 and they have a family history of breast cancer, they just start ordering breast ultrasounds. So I find that a lot, and then I end up seeing those patients because, like you said, many of them end up with abnormalities that then require follow-up evaluation.
Yeah, that's something, yeah.
And CDH1 is associated with lobular breast
Right.
cancer. It's associated with diffuse gastric cancer, and it is one of the worst syndromes to counsel because the recommendation is to remove the stomach. So it's difficult. And you can have cleft palate, cleft lip in the family with CDH1.
And our last question, using the 3-2-1 method that was presented today, which patients would be a good candidate for genetic testing? We have a 57-year-old female with a newly diagnosed stage 2A right breast cancer, hormone receptor positive, HER2 negative. Family history, his mother with lymphoma at age 56. We have a 43-year-old with no personal history of cancer, but has a family history in her mother with breast cancer at age 51. A 54-year-old with no personal history of cancer, but multiple relatives on the paternal side, including uncle with prostate cancer at 67, grandmother with breast cancer at 81, and father with prostate cancer at 72. And lastly, we have a 58-year-old female with a newly diagnosed triple-negative left breast cancer. These are the rationales. The initial patient, unfortunately, she doesn't have enough of a significant family history and is not under age 50. The 53-year-old, she does not have a personal history of breast cancer herself, and not as significant as a family history, but I would inquire with Dr. Negron about would you want to test the mom, or what more information
Well,
would
it
you
depends. It depends on the family history. We need to have a good family history. We need to know the type of breast cancer. And going to the first one, individual not under 50, now it's not difficult to get coverage. If the insurance doesn't pay for it, many labs have programs for anybody who had breast cancer to be tested. And this is based on a recommendation by the American Society of Breast Surgeons that mentioned that anybody who had breast cancer should consider genetic testing. And it's not, even though it will not be in guidelines, it will not be difficult to test the first one. It shouldn't be difficult. And then for the second one, we need more information.
So the 54-year-old female with the extensive history on her dad's side, she would be a candidate for genetic testing because, as we discussed previously, with multiple family members with breast or prostate cancer on the same side, they would be a candidate for genetic testing. And lastly, with the updated guidelines, all triple-negative breast cancer patients should be considered for genetic evaluation. And that was just a quick review of the 3-2-1 method we mentioned earlier. And then here's our summary.
Perfect. All right. A couple of questions that have come in, I just might ask you to comment on. So one has come in about those patients that have a pathogenic CDH1 mutation. What is the recommended screening for gastric cancer? You mentioned, Dr. Negron, about the consideration for recommendation of prophylactic gastrectomy. I know I have patients in my practice that are being followed at the NIH with random biopsies and sampling based on research protocols. How else are you counseling these patients?
Yeah, so there was again, it's very difficult to counsel, but there have been studies that have shown that people that have decided to do a prophylactic gastrectomy, and because they're gonna do that, they do before that random biopsies, and they're negative, and 95, I think, % of those will have lobular cancer already. So we don't force anything into the patient, but we mention to the patient this data, and it's something that they should decide, but they should know, like, when we say to the patient it's a good idea to remove the ovaries, what about doing the screening? And we discuss this. The screening is not good. That is the recommendation. So with the prophylactic gastrectomy and the screening, I will say screening is not great. The recommendation is this. I will send the patients to discuss. There are many many groups from CDH patients who can discuss. It's not difficult. It's not easy to discuss removal of the stomach. It's a lot. So TP53 and CDH1 are the worst two to discuss with the patient, because we're asking for a lot. But it's still recommended. I had a case, a very interesting case, and nobody in the family has stomach cancer. I would still say to her, because I said, sometimes we don't know if it's stomach cancer, because if there is stomach cancer, because this is, we come from, and this is we left the family behind, so we don't have all the information. And when we're talking about that, I received a call from the doctor. One of the 18-year-old family members, so I said nobody else has stomach cancer, now has stomach cancer. And she's 18. So this is why it's very important to discuss this in the family. The mutations can present in a different way even within the family. But all these recommendations that are very harsh is based on a lot of research and studies. And I wish we have anything better. But the problem with the diffuse cancer is when you go in, there is not going to be a mass, because it grows it expands. You don't see a mass. You will see something that looks maybe different, and the doctor can remove. But in some signs, it's not able to be seen because it grows in the inside and expand. And that is the problem with the CDH1.
We just have a couple seconds left. I wanted to try to touch on some questions that have come in from some of our virtual attendees. One question has been posed to the group coming from a radiation oncologist. Should we be considering genetic testing for all patients who have a possibility of radiation therapy in the future to help inform that decision?
I don't think so, because the probability of having a TP53 mutation is very low. And you can see, I said TP53, you don't see it in the family, but if we are nobody in the family, I will not recommend testing for the TP53. And for the ataxia for the ATM biallelic, the patient will have ataxia telangiectasia. The patient will likely be in a wheelchair and will have findings in the eyes, or because of the malformations, other vascular issues. So that will be, by the time the patient is ready to get a mammogram, that will be evident and obvious. And if you have a patient like that, yes, by all means, send for testing.
Perfect. Thank you all so much for attending our session today. Thank you to the panel members for joining me.